I'm going to call to order today, September 17th, 2024, the quarterly joint meeting between the Incarceration Prevention and Reduction Task Force Behavioral Health Committee and the Legal and Justice Systems Committee. We'll start with our land acknowledgement statement. Before we begin, we are gathered on, we acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. So I'm Stephen Gockley. I'm co-chair with Bellingham City Council President Dan Hamill of the Behavioral Health Subcommittee. Pleased to have you all here with us. This is a joint meeting. It's been an ongoing practice for us to meet quarterly with both committees because there is such a significant crossover in issues. Our agenda today reflects an ability to draw in some resource people to provide us with some baseline information on issues that have been very topical, very relevant, and very present in the course of numerous discussions held in numerous venues throughout the county effort to carry through on the sales and use tax initiative, the implementation plan, and the planning for reforming the criminal, legal, and community-based treatment programs. Flipping the order of the agenda, as Dan suggested, we will start with a presentation and a discussion led by Dr. Shannon Bustad, who is a medical advisor on opioid response for the Health and Community Services Department. Dr. Bustad, I believe, also works in CMAR's substance use disorder treatment efforts. He will be speaking on addiction support services, which are a key piece of our implementation plan. Dr. Bustad, welcome this morning, and I'll turn it over to you.
Thank you. Dan, I appreciate the invitation to speak today. So I didn't prepare any slides or anything, but my plan today is to kind of speak in general terms about my role within the department and give you kind of an update on where things stand, which are pretty exciting to me. And I think many of you probably already know, some of it or maybe even all of it, but I can give you a brief synopsis. So I am a family doctor. I've been in Bellingham since 2011. Over the course of that time, I've spent more and more of my practice on the difficulty and the problem with addiction medicine, and specifically opioid use disorder. CMAR offers a number of clinics around the state, from here to Vancouver, providing services to our affected patients. We have a dedicated adolescent clinic as well. Many of our clinics, including ours up here, offer both prenatal care and opioid use disorder treatment for pregnant patients. We have a number of associated services like case management and dental that we can help prioritize getting these patients in. As well, we've spent years facilitating and developing our connections in this community with providers and groups such as the GRACE team and the LEAD team. And through those interactions, I feel like we've done quite a bit for our community in terms of hopefully increasing the availability of opioid use disorder treatment. I just recently started. Last month was my first official day working as a medical advisor. So I'm spending a couple of hours each week working with the health department under Melora Christensen on figuring out how to leverage our available resources in this community to best meet the very challenging need for treatment for opioid use disorder. As you all know, we are, we've had the county executive's fentanyl response plan that we have been diligently working to enact through the work of the health department. We are developing an operations plan for gathering and disseminating information about the effects of different aspects of the response to fentanyl, both within the health department and through working with other agencies in the MAC group, kind of partnering with them so that we can provide up-to-date and accurate information, hopefully showing that with the processes that we're working on, that there will be a reduction in deaths, overdoses, and actually improvement in recovery in people's lives. I have been working with and meeting with a lot of the community organizations that provide opioid treatment services, both methadone and Suboxone, and determining that there is definitely a need for further integration. But I know that working within the hospital as well, there's a great desire, and there's a lot of people working on finding ways to establish treatment and allow very timely ongoing treatment with other agencies. Specifically, I can tell you about a project called Scala Northwest, which is a recent service offered by the HCA that the purpose of which is to provide an increase and enhanced likelihood of treatment continuation for people who are started on buprenorphine in either an emergency or in some places in the field by EMS, paramedics, and other first responders in other parts of the community. This is a brand new program. It is offered through the University of Washington as well. And basically the idea is when a person is started on buprenorphine, then they assist with working with the patient to get appointments with other local providers in the community. And the goal is to increase the likelihood that people will go from the first setting to the second. This meets a really huge need because historically and certainly ongoing, there's been reluctance among providers, either in emergency settings, in a first response sort of setting, in starting a medication that is very impactful and powerful medication that there's concerns both for safety of the medication, and there's also big concerns about follow-up. And are people, if you do provide this medication, are they going to be able to continue care? Because it is really important once you start buprenorphine or methadone that you do continue with it, because the effects work as long as you're taking the medication. But generally, once the medication is stopped, the treatment effect also goes away. So I will say that there are many interested outpatient groups that are working to establish relationships with Scala Northwest. And there's a lot of training that's going on in the hospital right now through that program and uh, other experts in the field to create good protocols and education for all members of the team in the emergency room, with the goal to increase the prescribing of buprenorphine when people arrive for treatment of an opioid overdose, or if they're just seeking treatment. The idea as well is for the health department, from our perspective, there are opportunities for that are growing for enhanced engagement within the emergency room. So embedding a substance use disorder professional in the emergency room to help facilitate both immediate treatment, next steps, and getting people engaged in ongoing care. In addition, there's going to be a response person, and Laura, you're gonna have to help me with the full acronym, but the idea of someone who's responding after someone has had an overdose and helping facilitate, the next steps, like figuring out where the patient is and what they need. And if that's a ride, then the health department also has someone available to assist with that, to get to appointments and things like that. So I think that the main things are an increased interest in finding actual solutions, in working with other organizations to improve the continuum of care and increase the probability of positive outcomes from the medication standpoint. And I will just say that in any venue in which a person who has opioid use disorder is started on treatment, it increases the likelihood of an improvement in their ability to have control of their own behavior, and they are much more likely to follow up with appointments. They're more likely to reduce their utilization of emergency services, and there does seem to be evidence that it reduces the likelihood of criminal activity as well. So like I said, I've been here for 13 years, and I think we're the closest we've ever been to really making things happen in a really positive way. I think that it is the case that we are already doing that in terms of stepping up to meet the need as a community. But as soon as we're able to all completely just connect the dots, I think that it's going to be a really awesome opportunity for us to start welcoming these individuals back into our community as productive and healthy, recovered people. So,
thank you, Dr. Boustead. Questions for Dr. Boustead? Peter Frazier.
Thank you, Dr. Boustead. I really appreciate it. I am wondering if we are looking at getting buprenorphine on the EMS rigs in the near future. And then I know that part of this model is, for its success, is follow-up visits, as I understand it. And I'm just kind of curious how is this considered a pilot project? Are we, some of those details would be appreciated, when we are going to be getting data back, et cetera. Anything you've got on that would be appreciated.
Yeah, I can speak to a little bit. In the MAC group, we at this month's meeting, the Scala Northwest, we received some updates about the Peace Health and their current plans to improve treatment for opioid visits. And I will say that right now, that is going to be the most impactful effect on the community in the short term. That will have a really huge effect by increased likelihood of the first prescription there, and then work on coordinating with other providers in the community. I will say that there does seem to be access in our community for accepting new patients from a variety of referrals. So I think that as soon as this actually goes into effect and the Peace Health emergency room providers are giving prescriptions, we're going to see a big increase in relationships with the community organizations. I will say that as far as EMS and first responders go, there is great interest in, and we are beginning the process of kind of getting the process going with offering that in the field. I think that there's a clear recognition that it's really a very important and powerful tool. But as far as like timeline, I can't give a timeline right now. I will say it's short in the sense of, you know, the last 13 years, and we actually have you know, it's on the horizon at this point. So and I really do believe that it's going to happen once safe protocols are you know, in place for the fire department and the first responders, but they are actively working on it. So yeah, I hope that helps. Was there other questions?
Brian Estes.
Yes, thank you for your presentation. My question really, it relates to what type of case management do you envision this program using, and does it differ from other substance use disorder case management approaches?
Well, that's an excellent question, and I will. I think that I actually, Melora, if you want to jump in on this, I think that you're going to be the one who's going to have a lot more to say about that.
Yeah, thank you, Shannon, and thank you, Brian, for the question. So part of these advancements are about having staff and support personnel in place after someone has survived an overdose, after they've interacted with EMS, when they get to the hospital and they're about to leave, right? That connection that is real. And so it's very exciting because all of this work kind of just snowballs on each other. And the hospital is partnering with Lifeline Connections to have an embedded SUDP recovery navigator position at the hospital. So that is already in motion. We got some one-time funding from the BHASO to support the start of that. So really grateful to our regional partner for that. And then we also got some one-time funding to have a response position. So in the response systems division, that will be an overdose prevention and response behavioral health specialist. And so they will work very, very closely with the person at the hospital, but they'll be able to take referrals from EMS, from the hospital, from other providers who know that someone has survived overdoses, has a history of overdoses, is at high risk of overdose and not connected. And then that person, along with our transportation staff, will do everything they can to actually find that individual, build some rapport with them, and connect them to, hopefully, MOUD services, but they could also support them in other areas. So it'll be a much more generalist position in which no one's going to be enrolled in a program, right? They're going to receive some recovery navigation support on whatever they're interested in connecting to. And we're going to do whatever we can to actually warm handoff connect them to that service, whether that's at CMAR or Cascade Medical Advantage or Ideal Options or comprehensive treatment, right? There's a lot of opportunities, and people will be able to engage in services wherever they see that, whatever makes sense. The other thing that we have in this is our nurse practitioner that's part of our street medicine program is also able to start induction of buprenorphine for someone who might be experiencing homelessness or not connected to a provider. And so that's another level of support within this continuum that we're talking about, because we just want to lower the barriers, right? folks are in crisis, they're suffering, they're cycling through this churn. How can we show up and try to get them to that next appointment? So it will be a hands-on direct service style of service delivery, but we anticipate working with all the SUD providers in town. We're also very excited to know that Deej will be opening their MOUD services at the Division campus. So that's yet another opportunity for this connector to get people into services. Does that answer your question, Brian?
That was a very comprehensive answer. So has some of this really not been tried before like this because we didn't have these positions before?
It has been tried. There's actually some really great programs across the country, and we've been using that to develop our pilot. I do want to say the position with the county is a temporary pilot position because we only have one-time funding. So it will kind of be a community process to determine if that should be continued. The health department is also considering if overdose should be a reportable condition through the state structure. And so that's another thing that we're looking into, and Dr. Bosted is supporting just that kind of discovery of if that makes sense, because if it was reportable, where would those reports go, right? They would go to this position who would then, this behavioral health specialist who would then do everything they can to connect with that person and get them into services.
Okay. Stephen Gockley.
Dr. Bousted, that's incredibly encouraging report, and Melora, thank you for adding to that. So I get the sense of sort of the continuum of services and the handoffs involved there and the potential for cycling back without those services. My understanding, and so I'm asking for your help in seeing if I'm right about this. My understanding was that the reluctance you spoke about was in the ED administering a first dose of buprenorphine because we didn't have the follow-up medical oversight to continue dosing an individual who was willing to go on that medication. So I guess I'm wondering, is that correct? Would the Deej program take care of our need for capacity and that follow-up care, or do we need the private practitioners to step up more, which is what I thought the bottleneck was? And what level of capacity do we really need, and how close are we to that?
Well, I can answer some of that. Those are those are really good questions. First off, I'll say that as far as the individual emergency room providers, I would, I can't necessarily speak for them, but I can say that kind of nationally and kind of anecdotally, what I'm aware of is, yeah, there is a lack of familiarity with the medication. It's actually kind of complicated to start some of these things, both buprenorphine or methadone, which is kind of a separate, process. But there's kind of protocols that have been useful in other places that have developed these processes, especially in places like California. I think that there's both individual education lapses or concerns about patient safety after they leave the emergency room, as well as kind of structural issues as far as all of the staff in the ER, and what do you do with these patients, like how long do you watch them, like various things like that, that there hasn't been enough time or resources to develop those programs. And it's just now that, it's been going on for a little while in other places, and because those there are leaders within emergency medicine physicians, there are established programs in hospitals that have protocols in place, that have training for nursing staff and for doctors, that this is just going to be a good opportunity for them to see the power of treating someone with this type of medication, rather than reducing an opioid, or reversing an opioid withdrawal and monitoring someone for safety, and then just kind of saying, go look for a treatment, actually having, here's your medication, here's your follow-up appointment, here's someone that you can call if you have questions or concerns. In the meantime, we're going to keep following up with you. As far as your question about capacity, I'm going to say that there is one large methadone clinic in town, and that I don't think people really know as much about. Bellingham Comprehensive Treatment Center sees like 400 people a day, or like those. That's the number that they see regularly. They do about 50 admits a month, sometimes less, sometimes more, and that I may be speaking on the high side, but there is capacity for both methadone. Traditionally, historically, most methadone clinics, while they may offer Suboxone or buprenorphine, they don't offer it in large amounts, and it's just not part of their general, their patient flow, I would say. But there are other, as Melora was saying, Lifeline Connections, Cascade Medical Advantage, Ideal Option, CMAR. Some people at Family Care Network are starting to offer it. Peace Health. There are a number of places, and I would say that there is capacity, and part of the reason there's capacity is because there are difficulties with people maintaining treatment. In fact, around the country, unfortunately, right now, it's about a 30% rate of people staying in a program at 1 year, which is very, very low. And a lot of that speaks to the importance of kind of all of the other aspects of life outside of medication that are really critical. Because if someone gets on medication, but then they're still, unhoused, or they've got untreated psychiatric illness or medical illness, or, legal, all of the myriad things that you can imagine, until we are able to start focusing on those as well, that it is still very challenging. But an important first step is engaging people in these treatment programs, which hopefully will at least stem the tide to a degree.
Okay, Melora, and then we're gonna have to move on here. We've got a few more agenda items. Go ahead, Melora.
I just wanted to add, this is when we talk about low barrier and no wrong door, like this is really the work that Dr. Bostad is working on, and so many others, which is there are so many intervention points in which someone should be able to access treatment and care. And that could be the ED, that could be a EMS crew that's responding to an overdose, that could be law enforcement calling this, making a referral, right? The dream here is that those opportunities are throughout the continuum, even a primary care provider knowing what to do if someone comes in and is struggling with this. And so it's very exciting work. And a big thank you to Dr. Bostad for taking a leadership role on this.
Absolutely. I echo that. Thank you, Doctor, for your presentation. It was fairly short notice, so I definitely appreciate the time here to present to the panel here today. And we jumped the gun just a little bit when we went into the presentation component of the meeting today. What I wanted to do, we have a very diverse group of people here when it comes to their professions and their backgrounds. And I'd like to just briefly go through everyone who's here on the call and just who you are and who you're affiliated with, just so we can have that background. So I'm going to start with the way the order is on my screen. So Melora, can you just start with that?
Yeah, Melora Christensen. I'm with Whatcom County Health and Community Services. I manage the Response Systems Division, and I'm a clinical social worker. And I'll stop there.
Okay, thanks, Melora. Peter Frazier.
I am co-chair of the Incarceration Prevention and Reduction Task Force.
Thank you, Peter. Lisa Marks.
There we go. I'm unmuted. I'm Lisa Marks, and I am with the Western States Regional Council of Carpenters, and I am a outreach specialist for our Career Connections curriculum. I work with many programs across the state, a lot that are within DOC, the Department of Corrections, all of the men's and women's prison systems across the state, and a lot of schools and pre-apprenticeship programs.
Excellent. And Lisa's going to be presenting here just in a little bit here. Dr. Shannon Boostad, if you're still there, it looks like you may have gone away. There you go. Just maybe your affiliations.
Well, the main affiliation at this time for this meeting is with Whatcom County Health and Community Services as a medical advisor for the opioid response. In addition, I've been a family doctor at CMAR for 13 years.
Thank you, Dr. Arlene Feld. I think you're muted, Arlene.
I'm a licensed marriage and family therapist. At this point in my life, I am training interns who are about to get their licenses and degrees.
Thanks, Arlene. Jill Nixon.
Hi, Jill Nixon. I'm a legislative coordinator for the Whatcom County Council Office and staff support for the IPRTF.
Thanks, Jill. Andrew and Lake Whatcom staff.
Yeah, hi, I'm a clinical mental health counselor and the outpatient program and clinical manager for Lake Whatcom Center. And to my left is
Nafarro Williams. I'm the residential program manager here for Lake Whatcom. I am a licensed social worker and a SED professional.
Thanks for joining us this morning, and we'll be hearing from them pretty soon here. Stephen Gockley.
Stephen Gockley, co-chair of the Behavioral Health Subcommittee.
Thank you. Raylene.
Raylene King, County Clerk, Superior Court, Whatcom. And prior to that, I was the administrator for Municipality Blaine. And I am currently the chair for the Legal and Justice Subcommittee.
Thanks, Raylene. Dr. Wu.
I'm Dr. Ying Wu. I'm a retired family physician, practiced here from 96 to 2022. And with Family Care Network, I'm with the Chuckanut Health Foundation as an intern. That's my retirement gig. I'm also serving on the Whatcom Racial Equity Commission. And I think that's it.
Okay. Thank you, Dr. Wu. Brian.
My name is Brian Estes. I have a 36-year career evaluating government programs, and also I'm the treasurer of the National Alliance on Mental Illness, the Whatcom County chapter, and I'm a member of the NAMI Washington, the statewide organization's public policy committee.
Thanks, Brian. And we're gonna, if time permits, we're gonna hear from Brian later. He's gonna make a presentation. Mike Hilly.
Yeah, good afternoon. Mike Hilly, Emergency Medical Services Manager for the county. And I've been on the member of this particular committee for 6 years. Also worked as a paramedic a little over 30 years down in King County, retiring out of there as a division chief. So yeah, thanks.
Thanks, Mike. Stephanie.
Stephanie Kraft, I'm the court administrator for Juvenile and Superior Court.
Thank you, Stephanie. Captain Larson.
Steve Larson, community paramedic for the Bellingham Fire Department.
Thanks, Steve. Jake.
Yeah, Jake B. Bush, administrator, district court and district court probation.
Thanks, Jake. Cedric.
Hi, Cedric Johnson. I work for Health Center Solutions based here in Bellingham. We do grant writing and federal grants, technical assistance and compliance for community health centers. I have clients all over the country, and through that work, often I'm learning about and getting to help evaluate various behavioral health and related models and treatment modalities that people are doing all over the country.
Thanks, Cedric. Heather.
Good morning, Heather Flaherty, here appointed as a citizen representative, co-chair of the Incarceration Task Force, and day job as executive director of the Chuckanut Health Foundation.
Welcome, Heather. Keith.
double video activation there. Keith Johnson, Bellingham Police Department, and worked several years with the Outreach Division.
Thanks, Keith. Executive Sadhu.
Hi, good morning, everybody. Sorry I'm late.
Welcome, Executive. Jenna. Yeah, she may have stepped away from her computer. Sheriff Tanksley.
Hi, I'm Sheriff Tanksley. Just trying to do great things for the entire community. I appreciate it. Thank you.
Thanks. Thank you, Tank. Jen, I don't know if you're back on or not. Okay, maybe not. And lastly, I'm Dan Hamill. I'm president of Bellingham City Council, co-chair with Stephen Gockley for this committee for behavioral health. This is a joint committee or meeting rather between the behavioral health committee and the legal and justice system. So you have some legal and justice folks here, and you have some behavioral health folks. And the agenda is pretty behavioral health intensive, but we aim to educate all the committees as best we can when it comes to the work that we're doing. And so I definitely appreciate the folks that are here to present today. And I just, by way of introductions, I just wanted to make sure that we all understood kind of the different roles and people that are acting within the sphere of behavioral health and incarceration prevention. And with that, let's and thank you everyone for attending today. We're going to be a little short on time. It's 12:09. We go until 1 p.m. This afternoon. So we're going to try to get through our presentations here, and I don't want to rush anything, but I want to make sure every question is answered and to make sure that we get the information that we need. Lake Whatcom Center, you are up.
Hi, again, my name is Andrew. Thanks for the invite, Dan. Appreciate it. I'm going to start by turning this over to my partner, LaFaro, who's in charge of our residential programs. Do I have the ability to display my screen?
Jill Nixon would be the person that would answer.
Yes, you should have a green share screen button at the bottom of your window.
I'm going to share this slide. Hopefully you all can see that.
Yep, we can see.
Great. LaFaro.
Hi, just want to introduce a couple of programs we have here at Lake Whatcom Treatment Center for Residential. We have our HEART team, which provides emergent stabilization for the community. They provide outreach, coordination of care, referral and resources for clients in the community who might be struggling with emergent needs and so forth. We work with DCR, other agencies that provide emergent stabilization as well. So that's our HEART team. We have an Alabama house here, and that is a assisted living facility. It has beds available for 12 clients at a time. Right now, we're at capacity. We're at 9 clients right now. To get into this facility, we require a COPES assessment. Then we have our Agate Heights facility, and that is a 67-bed facility. We take referrals from Western State Hospital, from the hospital, Peace Health, other places outside of the county. And then we have Baker Creek, which is our core caring facility. It's licensed for 32 beds, but right now we have 24 beds available, and we get referrals from the hospital and other community partners outside of the community as well. Basically, I'm here today to kind of introduce 2 new programs that's going to be starting up at Lake Whatcom Treatment Center, which is our Maplewood facility. That is an enhanced service facility, so an ESF. We're basically working with DSHS, and we'll be getting referrals from Western State Hospital. So this is a 16-bed facility. Most of our referrals are worked through DSHS, so we'll have a team working with them, but that's going to provide some supports for those who actually are at a place where they can leave Western State Hospital and come out into the community, but still need that support outside in the community as well. And then we're going to be starting our Birchwood facility. Go back to Maplewood. Maplewood will be opening around October, November-ish. But we're still working on staffing right now and getting things in place to open that facility. And then we have our Birchwood facility, which was the old Avamere building, and our Agate Heights facility and our Alabama House facility will be combining to move into Birchwood. Plans for that facility was a 68-bed, no, it's a 86-bed facility. We'll be combining all our clients that's already existing in each facility to that facility. Basically, we're working with SMI. We'll be taking the same referrals. We are not going to be requiring a COPS assessment for now. That's what we're stating. And that facility should open up next year at some point. We have plans to open up this year, but due to funding streams and things needed at the location, we weren't able to open up this year, but that should be coming soon. So those are my updates for residential. Any questions?
Committee, Peter Fraser, go ahead.
LaFaro, thank you so much. Just got COPS. Would you explain COPS and then funding? Where does your funding come from? Can either of you speak a little bit to that in general? And then how are you guys doing with workforce these days?
So with the COPS assessment, you can go, it's basically, oh, my battery's running low. Sorry about that. With the COPS assessment, basically it's a assessment from a social worker from either HCS or Northwest Regional Council. And they come in and check they check medical needs and other needs that a client might have. That's pretty much high needs. So a person can either be assessed to meet the level of care for a skilled nursing facility, an assisted living facility, adult family home, or also in-home caregiver hours. So that's
Sorry, guys, we're moving closer to an hour.
So that's how the COPS assessment works. You basically will set up through home and community services to get a social worker to provide that COPS assessment. So you can see what kind of extra support a person might need in order to help them with their level of care. And then your other question was? I'm sorry.
I'm just curious about funding for Lake Whatcom Center, just in general. I know that that's a complex issue, and then also, how is workforce for you guys? I know that it's been really tight. Are things changing?
Yeah, great question. Most of our funding comes through insurance billing, whether it's Medicare, Medicaid. As you notice, a lot of our facilities are limited at 16 or some multiple of 16 because of the Medicaid limit to 16 beds total. So Medicaid, Medicare, primarily our funding source. We're not having problems filling seats as far as workforce goes. And I'm afraid this laptop's going to die. So I got to find an outlet that's working, because we're actually in our new facility and they're playing electrical games. We're working on staffing this facility currently. But if you, does that answer your question?
It does. Thank you very much. I'm really glad to hear your workforce issues seem to be loosening up.
Okay, I've got Brian and then Stephen. Here, give me that cord.
Yeah, I want to just drill down a little bit on the differences between private insurance and Medicaid reimbursement for behavioral health. I know there have been some increases in those Medicaid behavioral health rates, but could you just comment on how that impacts perhaps your budget, and what are you thinking in terms from the state legislature about Medicaid payments for behavioral health?
We may have lost them because of their
Yeah, I think we
did. They were having issues with their connecting their computer.
Okay.
Okay. Well, let's see. Okay. Yeah, I had a question too as well, but let's maybe give them a minute to re-plug back in, and we can put them back into the agenda queue after Lisa Marks makes her presentation. Lisa, are you still on? There you are. Yeah, let's go ahead and move to Lisa with the Carpenters Union with the reentry program that she's been working on. And we'll circle back if our Lake Whatcom friends are able to rejoin us. So Lisa, go ahead.
Okay, thank you. Thank you so much for having me here today, and I'll try to make this as quick as possible. I do have a PowerPoint if I am able to use my share my screen.
You have a green share screen button at the bottom of your screen.
And just while Lisa's queuing up here, hey Andrew, we moved to Lisa. We're gonna go back to you guys. Is that okay? Okay, we'll do that, and yeah, let's go to Lisa. She's got a brief presentation, and then we'll come back to Lake Whatcom. Go ahead, Lisa.
Okay, thank you.
We can see the screen.
You can see it. Okay. So let me see. I've got this other thing in my way, and so now I can't get it to. Oh, there we go. There's slideshow. Yay. Okay. So I wanted to talk about the programs that we've been doing already for all of the prison or incarceration facilities across the state of Washington, both in the men's and females programs. It started with this program called TRAC, which is Trades-Related Apprenticeship Coaching. It is a pre-apprenticeship program, and it is 16 weeks long, and it is 460 hours. And through that program, the students are able to gain skills in the trades. And hopefully once they're released, they can go straight into a pre-apprenticeship program and have a good living wage career right from the get-go. So they come out, they get indentured as an apprentice in the trade of their choice, and then they're able to hopefully make a good living wage. Majority of the trades start at about $35 an hour for a beginning apprentice, and they get full benefits. So along with that great wage, they also have all their medical, and dental, and it's definitely life-changing. I can say I started in the field, and I was a 43-year-old woman before I found my way into the apprenticeship program. And it seriously changed my life. That's why I love doing this so much, because I know how much it works. So the good news is Jay Inslee yesterday, our governor, we are the second state in the nation to have an executive order signed that is hopefully going to break down the barriers for folks who are reintegrating into society after being incarcerated. So they are hoping for this is called a Reentry 2030, and they are hoping that within that time frame they will see at least a 40% increase in folks who are actually being able to have that second chance once they are released. This is a little bit more of what they talked about at the program. They're looking for hopefully zero returns for homelessness. Like I said, 40% of individuals released from incarceration will be employed within 6 months, and then healthcare. So what this is hopefully going to do is just break down those silos, break down the barriers between services, and make a more seamless process through getting everything through. And then I was going to go into a little bit about the curriculum that they're using. So they're using our Career Connections curriculum, which was developed at our International Training Center in Las Vegas. This program was designed primarily in the beginning for school CTE programs. And I have been working with a few programs in our area. Ferndale is very interested in the program, and Lummi is actually using it for their pre-apprenticeship program currently. But it's a great program. We have probably 55 schools across the state that are using the curriculum. It's got all the many books that go with it. There's 8. Starts with One Trade, Many Careers, where it tells them about all the different pathways that they have to choose from. Because even under the umbrella of carpenters, we've got many different apprenticeship programs they can choose from. Math for the trades, of course. We have a book that's specific for our millwrights. We have the oxy-fuel cutting. We got project books 1, 2, and 3. Project book 1 is your beginning book. It's going to have all those basic first skills. They're going to learn all the beginning safety's big, you know, and then just the materials and all of that. I'm not going to go into all the details because I know we're close on time, but it's got all of this, all of these different projects. It's super easy to teach, which is why it's so easy to implement in all of the schools and the different facilities, because everything is already done for the instructor. Even somebody who doesn't necessarily know how to instruct carpentry can usually learn very quickly how to teach out of these books because everything's already been done. They've already got all of the project details. They've got all of the skills matrix and everything done. They have the safety operation checklists all done. And then they've got timelines and guidelines for folks who are, you know, putting it into the schools. This is an OSPI state recognized curriculum. So it has been already passed through OSPI and has been approved. We have a blended learning opportunity as well, where you can have the physical books, and we also have an online LMS system that folks could use if they want to. Of course, within all of the correctional facilities, it's nice that we have the physical copies because they do not have the access to the learning management system. So they work directly out of the books for their classes. And this is just a little bit more about the program. Here's the big thing right here. As they go through and they pass each level of competency, they get these certificates of completion. So with the certificate level 1, level 2, and level 3, those are the certificates that get them the entry into our apprenticeship program. And they are able to receive these certificates while incarcerated and, you know, doing the program right there inside the facility. And so when they come out, it's a much easier, seamless transition into the apprenticeship program. And this is just a little bit about the requirements out of each book or each level for the certificates of completion. And then that's about it. So that was it in a quick presentation. So what questions might you have for me?
Thank you, Lisa, for the presentation. I just want to note before I take the question from Peter and any others that are queued up here, this is one of the areas where we need a vast amount of improvement when it comes to vocational rehabilitation, coming back into communities, and we have a lot of work to do. And that's one of the reasons I invited Lisa Marks to come today, because we have a lot of work on this one. Go ahead, Peter Fraser.
Hi, Lisa. Thank you so much for your presentation. Of course, those of us on this call are likely all have a similar question, which is what sort of opportunities are there for our justice-involved population here in Whatcom County who are cycling in and out of a county jail, and not necessarily a DOC facility? Are there intercepts? Are there ways that we can take advantage of this program in this county?
Well, as you know, Whatcom County is growing. I mean, all over the place. Bellingham has just been doing their Bellingham plan, and there's big growth plan for over the next 10 years. I just went to a meeting last week. They had a meeting at the Bellingham Public Library on the 2 mega projects that are actually going to be coming to our area. So there's going to be 2 mega projects on the US side, and most everything that anybody would be coming out of county for they would not have a problem getting on that project, even though it's, you know, at a border crossing. Those projects are going to be huge, multi-million-dollar projects. So there's going to be a lot of work with those, and those are going to be starting in late 2025, 2026, I believe is when those are supposed to begin. And it's just gonna create a lot of opportunity for our area for growth in the construction trades. And, you know, for whether it's young folks coming out of high school or folks coming out of correctional facilities or, you know, just folks in the community looking for careers. There's gonna be a lot of growing. I mean, you look around Bellingham right now and you see things going up everywhere. There's construction everywhere, especially infrastructure type work.
And just to put a finer point on Peter's question, so I believe the question was, can people who are exiting or currently incarcerated in the Whatcom County local system versus the DOC system, do they have these opportunities to access the programs that you were just speaking to?
Yeah, if we were to get a pre-apprenticeship going in the area that would utilize the curriculum, yeah, we could, the whole thing would be getting a program like this started, finding an entity or an availability to get the pre-apprenticeship going.
Okay, so there is some bridge work to be done in terms of like that process has to happen. Okay, that's
Mhm.
very
And there's
good.
there's partnerships that could be done. You know, we've got plenty of folks, like there's a program called Anew, and they'll travel. They could run programs for you, you know. So I mean, it wouldn't necessarily have to be where you'd have to start your own program. You could always partner with an existing pre-apprenticeship program where they could come out and go straight into it. Because I know the DOC, a lot of times once their folks are released, they go to Anew and get more services from them, because Anew also offers support services. So they help them get their tools. They help them get, you know, a lot of the other things that they're going to need to come in. So they've got support services built in as well. So I'd say probably a partnership would be the quickest, easiest route to be able to get something like this started.
Okay, thank you, Lisa. I've got Sheriff Tainsley. Go ahead.
Yes, I just want to chime in that I would love to have a follow-up conversation about that. So certainly something I'm interested in.
Okay.
Sounds good.
Yeah, I think there's plenty of there's no lack of interest, Lisa, when it comes to this committee and its membership when it comes to this vocational component of what we're talking about. Arlene Feld, go ahead.
Yes, well, I think it's a really great program, and of course, we need that for ourselves. But we've been told that the 40% of the members of the jail do not read.
Mm-hmm.
Do you have something for that?
That's where a lot of those partnerships would be helpful. And we've had, you know, I can't tell you how many apprentices we've had come through that don't read, but can learn how to read a tape measure, you know, and it's learning. And we've broken a lot of barriers like that. We've even got, you know, carpenters who have physical disabilities, you know, deaf, or, you know, have some other things. And, you know, we find ways to work through it to help folks to be able to break those barriers.
That's great.
Mm-hmm.
Raylene, go ahead.
What are the requirements to enter some of these programs? I know, you know, some of the people that are incarcerated have mental health issues or have drug addiction issues. Are there ineligibility for any of this program?
They would need to be able to pass a drug test in order to be able to come into the apprenticeship program. And that would be, you know, for safety concerns, you know, going on to a construction project and stuff. So yeah, they would definitely need to pass the drug test. However, we do have plenty of members who use methadone, Suboxone, you know, and are going through treatment programs. They just, you know, have to be able to test positive should they be, you know, coming into the program.
And how long do they have to be?
Or not test positive.
Yeah.
Yeah.
How long do you expect them to be clean before you would accept them in that program?
I would say just when they get ready to do the apprenticeship program, to be able to have a clean test once they, you know, test in for the program.
Okay, and then on mental health, is there restrictions there?
You know, it would depend on what it is. So I'd have to learn more about what you're talking about with mental health before being able to answer that question.
Okay,
Yeah.
thank you.
Mm-hmm.
Dr. Wu, you had your hand up. Do you still have a question?
No, it got answered.
Okay. All right. Thank you. Stephen Gockley, go ahead.
Lisa, thank you. You're with the Carpenters Union, but there's sort of a core skill set, soft skills, you called it in one of your slides. And there were some apprenticeships that didn't look to me, at least, as if they were carpenters apprenticeships. So does this connect to a lot of the trade unions and take advantage of apprenticeship opportunities in other fields besides the carpenters union?
Yeah, most all the pre-apprenticeship programs do offer multi-trade pathways. You know, so they could go into laborers, they could go into carpenters, they could go into operators, they could go into labor, or I already said labor, cement masons. You know, there's many different career paths. And then as I was saying earlier, carpenters, a lot of people don't realize, but we've got a lot of different crafts under our umbrella. So millwrights, which would be conveyor belts, wind turbines, a clean energy, solar, a lot of that is under the umbrella of carpentry. We've also got pile drivers, scaffold builders, which is what I did out at the refinery, shipwright boat builders, insulation. You know, we've interior systems. We've got many different pathways, even just under our umbrella.
Thank you, Lisa. I think I think the challenge for this committee is to think about how we can connect the work that we're doing with the available opportunities when it comes to this, what I would regard as vocational rehabilitation, what Lisa's referring to as apprenticeships. How can we better do that work when it comes to folks that are currently incarcerated in Whatcom County Jail or are in some kind of diversion program, whether it's LEAD or GRACE, to divert them into these very well-paying jobs that provide a pathway for being able to pay your rent or to eventually, hopefully, own a home. And so thank you, Lisa, for coming today and giving us this outline of the work that you do. We definitely appreciate the work that you do within DOC, and we want to see how we can extend that to our local jail system. So thank you, Lisa, for your presentation today.
Absolutely. Happy to be here, and thank you for having me.
Yeah, definitely. I think that I think Lake Whatcom's back on the call. Did you guys found a plug-in to put your computer in?
Yeah, we did. We're great program managers and clinical people. We're not very good IT people.
It's all good. It's all good. There was a question in the queue from Brian Estes. That I wanted to make sure that question got answered. And if there were any other items or things that you wanted to follow up on, that you had an opportunity to do that. But first, I'll go to Brian with your question.
Yeah, I want to follow up a little bit about reimbursement and the differences between private insurance and the Medicaid rate for behavioral health. As you sure know, the legislature has been attempting to raise that Medicaid behavioral health reimbursement rate. But can you just comment on the Medicaid reimbursement rate and how that, impacts your organization?
Sure. Good question. I should probably run through our outpatient services model because it'll kind of help explain it. Obviously, based upon level of care, the reimbursement rate changes. If you're working with somebody at the community case management level, or even as a therapist, it's a much lower reimbursement rate than if they're in your intensive outpatient program, or if they're in your PAC, your program for assertive community treatment program. So it's really dependent on program. It doesn't so much negatively impact us on the outpatient side because our case manager to client ratio is generally pretty high depending on the level of care. It's limited in the WACs in the IOP level of care to 15:1. Where it really hurts is honestly in the residential programs where we have, for example, this extended service facility, Maplewood, that's coming on board for people with high medical needs and SMI that have timed out, for lack of a better term, out of Western and can no longer, for forensic reasons, be held. And yet you can't just release them to the street because they have uncontrolled diabetes or other medical complications. You know, we're held to the 16-bed rule, which has been in place since the 1950s. And we actually overbuilt this facility, hoping one day that the legislative body will unblock that rule. But it's really tough to staff with a 4-person minimum with an RN 24/7, 16-bed facility. We're looking at hiring almost 20 staff. Most of them are going to be CNAs, RNs, and whatnot. Well, when your reimbursement rate is held to 16 beds when it could be 32 or 40 or whatnot, you really, on the business end of things, start running out of ideas really quickly. So on the outpatient side, we've noticed that the acuity level has changed over time. And because of that, I'm just going to pull up a slide here, and I'll show you how we revamped our model of care on the outpatient side of things and how we're growing. On the left-hand side of your screen, you should see our 2 new IOP teams. We used to have 1 7-person IOP team. We now have 2 10-person IOP teams, which will be able to serve 300 people at the intensive outpatient level of care. We use the LOCUS tool, which is the level of care utilization system tool. It's an evidence-based tool to determine what level of care everybody needs. The IOP level of care is a level 3. It provides case managers the opportunity to meet 2 to 3 times a week with clients. Probably in our IOP teams, about 20% of our clients are homeless and or struggling with substance use. Our CCM team used to be much larger, but we're finding that as we actually adjust our level of care for that to be a true LOCUS level 2 group of individual, they're able to handle between 70 and 90 clients, because these are clients that generally don't need case management, that we interact with once every 3 to 5 weeks, more life coaching, accountability than pure case management. You'll see that we have a PAC team. Currently we have a half PAC. We have applied to the legislature to become a full PAC. We won't know until June, but we serve 50 clients in the community. 60% of those clients are unhoused, and almost the same numbers, like 58% of them, are currently struggling with active substance use issues. We do have an employment services team that offers supportive employment for clients, and a therapy team as well. So we've taken our model and kind of, instead of being very heavy on the community or the LOCUS level 2 level of care, we leaned into what we've seen as an increased need and an increased level of care need, especially since COVID. About the last 3 years, we've watched general acuity of clients increase. So in order to do that, we've increased the size of our IOP teams. IOP does reimburse at a much greater rate than case management at a community level, and PAC even a little bit more, but the PAC is funded by the legislature, and so you can't just add people to your PAC team. You have to be designated funds for that. So I don't know if that answers your question really well, but it really comes down to reimbursement is tougher on the residential side than it is on the outpatient side. It is minute for minute insurance billing in general. So if you spend 5 minutes with a client or an hour and 5 minutes with a client, it's different. Of course, we use different metrics to prove that we're, to the insurance companies and the MCOs, to show that we're actually making progress with clients, as well as have treatment plans that we have to write and create every 6 months. So that's where we're growing as an agency. We're currently serving about 800 clients. Our big push with LaFaro in charge on the residential side is that we take a lot of clients from either unhoused or coming newly out of the jail, and partner with Lifeline Connections that gives us some referrals. And we'll put them into our substance use facility for up to 90 days. And then we have a shelter bed facility that they can stay in for another 90 days to continue to demonstrate their recovery. And then we have 254 beds or rooms that we rent. We own all of our own properties here at Lake Whatcom Center. So we, as a landlord, have 254 rooms. And generally we'll see people go from unhoused to Baker Creek to our shelter beds into our landlord tenant housing. And so that's kind of the model that we are pushing. And then depending on where people are at as far as level of care and how much help they need, they might be assigned to our IOP team or our PAC team, which actually has a couple clients that we're meeting twice a day, 7 days a week.
I'll go ahead and recognize Stephen Gockley, then Peter.
Andrew and LaFaro, thank you so much for this presentation. Kudos to Lake Whatcom Center for the way you've always stepped up to community needs, the way you're creative and looking for new ways to serve those or expanding the services you have. And you're really doing a lot and planning a lot. I'm particularly interested in the residential side that LaFaro was talking about, because that's a supported housing opportunities are a critical piece of some of the criminal legal reforms and diversion programs that we've committed ourselves to publicly on this. Are there specific protocols that would be required, or are they already in place to take diversion referrals into some of your residential placements? What kind of lift would that be to connect the kinds of people we're working with coming out of or being diverted from the jail into a need for supported residential care?
Yeah, that's a great question. I can actually answer that, since those individuals would have to come in through our outpatient program. So a client being released from jail would have a pre-screening done by LaFaro and the head of his heart team. And then when released from incarceration or diverted, let's say, because they, either the mental health court or another program, they would come into our outpatient services, and as such would need to engage in outpatient services. And then if there was a substance use concern, because generally we're finding that jail time does not equal sober time. And so after somebody's been in our community for a little bit and either continuing to present as not using if they had a using issue prior to being incarcerated, or even if they want to explore sobriety in some aspect, we'll send them to, or ask them if they would like to go to our Baker Creek facility, and then there from our shelter beds, and then there into a lease. And then they would maintain case management the whole time on the outpatient side. We don't, at our Agate residential facility, take people diverted from incarceration into there. Soon, when Agate and Alabama are two different facilities, merge into our Burchard location, we will probably be turning our Agate facility, which is up at Agate Heights on the other side of the lake, into a 34-bed clean and sober living for people just like you're talking about that are being diverted. We don't take direct diversions without them going through some sort of inpatient treatment or being involved in case management. We've found, unfortunately, that when we have attempted to take people and do an intake in the jail and then move them straight into services, we've ended up with some violence towards staff and aggression issues that we were unable to foresee because or people will just stop engaging because how people present when they're incarcerated sometimes is very different than when they get out and they start using again.
Thank you. Recognize Peter Frazier.
How would you characterize the gap for the population that you are working with as for programmatic gap in our community? I know it's probably a huge question. I'm just looking for a quick assessment from you.
Yeah, that's an easy assessment. Housing. Some sort of supported zero barrier entry housing. I find that, I sit around all day trying to think of the best therapeutic arc for our clients. And invariably, when I sit down with a client and we talk about like the milestone of recovery scale that Dr. Reagan's came up with, if you have don't know who that is. It's a wonderful read. And you look at what interventions a client is willing to take as opposed to what I think is best for them. 99 out of 100 clients that we're working with that are unhoused will say, I just need somewhere to live. And it's been fascinating that as we've worked with Opportunity Council, a highly valued partner, to be able to house some clients that were maybe a little more in control of their substance use, even though it may have been methamphetamines or fentanyl. And as they got housed, watch their stability increase, watch their engagement in programs like Lisa is talking about increase. But yeah, honestly, the biggest gap is low to no barrier housing. You know, love Francis Place, love 22 North. There are just not enough beds like that in supported housing to really make a difference. I mean, we have clients that use, I mean, one client in particular I was talking to, she is sexually assaulted almost every night. And so because of that, she does meth and fentanyl every night. So that way she doesn't have to be awake through it. And her antisocial behavior, unfortunately, preclude her from being able to stay at base camp or any of the other places in town. Love to be able to house more people and then work from there. When you're trying to deal with, you know, the Maslow's hierarchy of needs, as we've all studied, people that have no basis through their pyramid, where they live in a food desert or they don't have housing, and then you're trying to talk to them about therapeutic ways to use CBT for psychosis to try and change their mindset, or even engage them in some of the wonderful things that the doctor was talking about earlier, you know, but then they're still discharging back to the street. That's tough.
All right, thanks for those answers. I want to provide just a little bit of context real quick here as it relates to housing, since that came up. Tomorrow I'll be meeting with our state delegation along with the mayor's office and some other council members to talk about our legislative priorities. As you all know, the Bellingham has been a leader when it comes to housing. Bellingham Home Fund was a voter approved measure twice now that provides for about $4-ish million per year. And then 3 years ago, House Bill 1590 was voted councilmanically, which means by the vote of the council, to provide another $3 million per year, 40% of that which goes to mental health, and 60% goes to housing. We have recognized for a long time in this community that housing comes up in every conversation when it comes to how to stabilize people and how to help them get out of the situations that they're in. However, the local dollars are not enough, and we will be continuing to go to our state delegation, and we've hired a new lobbyist firm with the city to go for more housing dollars. This comes up in about an hour and 10 minutes. I'll be working the food bank line out at Cordata, and the 127% increase of people that are visiting us today will be, most of them are asset limited, income constrained, and employed, or ALICE folks. It means that they have jobs, they're working, they're doing what they're supposed to do in society, but they can't make the ends meet. And so, and housing is the major culprit when it comes housing affordability or insecurity is the major culprit when it comes to this. And they're having to make choices when it comes to, do I pay my rent, or do I buy food, or will I sit in the food bank line for 45 minutes to get a box of food? And that's where we're at right now. When it comes to people that are incarcerated, justice involved, or about to be, that's a consideration that happens in these discussions. So I just wanted to give you that context that we as a local legislator, we continue to work on these items as best we can. And there's definitely a delta between where we're at and where we need to be. Andrew, I saw your hand up. Blake, welcome.
I just wanted to point out that, you know, I'm not being critical of what we're doing. And I recognize, Dan, that you guys are doing some really amazing things with housing. But like you said, it takes more than just local dollars to really, you know, especially with what real estate costs nowadays. You know, we're always on the look for more housing opportunities, because we found that if I can house somebody, I have people that care enough and are skilled enough that they will engage and lives and choose to change their lives.
Yeah, I recognize that. I wanted to just say thank you to Lake Whatcom for the amount of housing that you do provide. I was on a ride along with the community paramedic program. I think Captain Larson's still on this call, and the Grace program, and we went and visited a client who's in your housing, and it was, I had no idea that you provided that much housing, which is so thank you to your whole team for doing that work. It's definitely needed, and we need more of it for sure, and we'll be working to that end. Brian Estes, go ahead. Brian, I think you're on mute.
I just want to say real quick, Dan, this is a little bit off topic, but in terms of legislative priorities on the capital side, there is a dire need for a pediatric inpatient facility in the North Sound region. And the ASO did an analysis of capital facility needs some time ago, and that was their #1 priority. Children sit at Peace Health sometimes for weeks or months because there's literally nowhere to place them, even nationwide. This may not fit in with your agenda today, but I just wanted to mention that.
No, I appreciate that. We revisit this topic of upstream prevention all the time. So it's something that comes up in these discussions. We're running out of time here. It's 12:54. I want to make sure that we respect everyone's time and get us out at 1 o'clock. And I do know that we've got some folks in the gallery here. We've got like 2, 4, 6 folks. I want to provide Jill Nixon an opportunity for them to provide comments. I know that some of them are potential new members of the Behavioral Health Committee, and I just wanted to provide this time, if we're okay with transitioning to that period in our agenda. And Brian Estes, can we just go ahead and move your agenda item to the next meeting? Is that okay?
It's deja vu all over again.
I know we keep. I'm sorry.
No, these were 3 very stimulating, very worthwhile presentations. So what I'm talking about, there's no timeline on it. So
okay. And before we transition into potential public comment, I do want to thank the presenters today. Everyone had great things to say, and I think that and these are all big topic areas that we need to be very mindful of and be addressing. So thank you for coming today. Thanks for sharing your wisdom and the work that you're doing. We appreciate it. So Jill Nixon, I want to move to public comment and provide our guests here today for their opportunity to speak, and we should probably constrain it to a couple minutes each.
Thank you, Dan. Yes, we do have a number of attendees. If any of you would like to speak to the committee, please virtually raise your hand now. No hands are raised. Peter, is there anyone in the conference room with you?
I'm all by myself.
All right. Thank you, everyone.
Okay. Well, it looks like we're going to buy 4 minutes of your time back today. So thank you all for attending, and thank you for being a part of this committee. It's absolutely appreciated. We know that we have a lot of work to do, but thank you for the work that's been done and the continuation of what's to come. And with that, I'll go ahead and adjourn the meeting.
Hey Dan, just really quick, could Jill put together a list of the new committee members and maybe just briefly summarize what they said in terms of their background in writing? That would be helpful for me going forward, to just know when people are raising comments, what organization they're with. That would be helpful.
Absolutely. Yeah, we're doing that, and we're onboarding folks onto this committee. It's a process. We're asking them to come, be an attendee, and then kind of see how we work, and then ask them to formally join the committee. And Stephen Gockley and I know Stephen had to leave he's on the Bellingham Housing Authority board, and he had a meeting here in a couple minutes. But we've been doing those meetings to try to bring more people on with a diverse kind of perspective. So, but thank you, Brian, for bringing that up. But with that, I will go ahead. It's 12:57, and I'll go ahead and adjourn this meeting. And thank you, and have a good rest of your day.
Dan, can you stay behind for just 1 second? I've got a quick question for you.